Chapter 48 will focus on disorders of musculoskeletal function, specifically trauma, infection, and neoplasms. And we're going to focus our attention primarily on issues with the skeletal system. So, musculoskeletal injuries can be caused by a lot of different things. Blunt tissue trauma, we can have disruption or damage to tendons and ligaments, or fractures of bony structures, which again is primarily what we're going to focus on in this presentation. So we classify fractures in several different ways. So they can be classified based on their location. So you can see here how we split that bone into proximal, midshaft, or distal. So depending on where the fracture occurs in the bone, that's one way we can talk about that classification. We also talk about these by the direction of the fracture. So whether they're transverse, oblique or spiral, which you see here. So transverse would be straight across, oblique would be kind of an angled fracture through the bone, and spiral is kind of a just what it sounds like, kind of like the spring of a pen, usually caused by some kind of twisting motion at the time of break. We also can talk about these by type, what we call comminuted, segmental, butterfly, or impacted, and you can kind of see those here. Comminuted is when there's a portion of the bone that's almost, I don't know, kind of broken up, small parts. Segmental is where a chunk of that bone is a bit displaced. Butterfly, where we're not all the way kind of through, just a small segment. And impacted is usually caused by some kind of like what it sounds like, impact, where the bone is kind of pressed into another bony area. We also can talk about these by type as either open or closed. An open fracture means that the bone itself has been displaced to such a degree that it penetrates through the skin, the soft tissue and skin, and closed, there's no penetration through the skin. We also can see things like green stick or partial fractures where we don't go all the way through the bone. I don't have any little pictures of those, but those are more often seen in children, just because of the differences between the makeup of a child's bone versus that of an adult. So signs and symptoms of a fracture. Pain is one common sign. Tenderness at the site of the bone disruption. Significant swelling in the area around the fracture. Loss of function is very common. Inability to bear weight, inability to move the extremity. We can often see maybe deformity of the affected part, whether it's, limbs, wherever it is, and then abnormal mobility or movement. So when a fracture occurs and requires treatment, these are some of the treatment methods or goals with fracture. The first one, there are three kind of main objectives for the treatment of fracture. One is the reduction of the fracture. And reduction means realignment of the bone. So if you think back to some of the pictures about the descriptors of fractures, often, what you saw in those pictures were that the ends of the bone, the two kind of broken ends, were misaligned, moved away from each other. So the first step here is to reduce that, again, bringing those two pieces of the bone back together so they're completely kind of lined up. And the reason for that will make a lot of sense when we start talking about the way that bones heal. And we can do that realignment a couple of different ways, and how we do it often depends too on the severity of the misalignment, the type of fracture that we see. But we can do this either through what we call closed manipulation or closed reduction, or through surgical reduction. And closed reduction or manipulation is a non-surgical way where we just physically manipulate from the outside of the extremity, that bone, to kind of move the ends of it back into place. Patients are usually sedated, have pain medication, while that manipulation is occurring. Open manipulation or open surgical reduction, excuse me, is through a surgical means to move the ends of that bone back into place. And there might be fixation devices that are kind of placed at the same time as that were to occur. Um, the next step after reduction is immobilization. And so that's going to prevent movement of the injured part. And it is the single most important element in obtaining what we call full union of the fracture fragments. So bringing those two sections fully back together in that healing process. We use external devices for immobilization, things like splints and casts or traction or external fixation devices. And we can also use internal devices, internal fixation like plates and screws to hold things together. So you can see kind of in my picture, this is an internal device with a plate and several screws in through the bone to bring together, here's my two broken segments of that bone back together. This is actually my son when he was 4. That's his little femur, post-surgical internal fixation. The picture here is of what we call traction. We often use traction early on, maybe prior to surgical reduction, to kind of bring more alignment to that bone area. A lot of the time traction is used again pre-surgery, maybe for pain control and reduction. When we have that misalignment of the bones, it causes a lot of damage and pain. When we have like kind of a change in how the muscles are set, they'll cramp and cause pain. This is also my son's little feet here in his pre-surgical traction. Okay. After reduction and immobilization, the next step is this preservation and restoration of function. So while someone is healing from a fracture, during those stages of immobilization, we see things like changes in stiffness to joints that are immobilized. We see things like atrophy and changes to the muscle. If someone is casted, once that cast is removed, we can see significant atrophy. And so in addition to making sure that bone is aligned, post-fracture, we often see these folks in therapy to restore a lot of the kind of soft tissue changes and joint changes that go along with fracture. Okay, so I mentioned we're going to talk about the stages of bone healing, and you'll see why kind of some of those goals of treatment of fracture are so important here. But there are 4 main stages of bone healing: hematoma formation, the inflammatory phase, reparative phase, and the remodeling phase. So we'll talk about each of those. So here's our hematoma formation phase. So when a bone breaks, blood vessels in the bone and the surrounding tissue are torn and they bleed into and around the fragments of that fractured bone. They form blood clots or kind of a hematoma in that area. And that hematoma is important because it helps to facilitate the formation of what we call the fibrin meshwork. And that meshwork will seal off that fracture site. And it also serves as a framework for the influx of all the inflammatory cells, the movement of fibroblasts into the site, and the development of new capillary buds or capillary vessels at the site of fracture. It's also that hematoma is also the source of signaling molecules that initiate cellular events critical to the healing process. So all that hematoma formation is sort of laying the groundwork for kind of the next stages of bone repair. So the next stage is the inflammatory phase and callus formation. So as these new capillaries start to infiltrate the hematoma at that fracture site, it starts to become organized into a form of granulation tissue called procallus. Okay. Fibroblasts from the periosteum and the endosteum and the bone marrow start to proliferate and invade that procallus area. Fibroblasts produce this fibrocartilaginous soft callus bridge. You can kind of see that right through here, that connects the bone fragments. This thing will kind of start to grow usually through the second and third week of bone repair. So there's kind of tissue that forms between those bone fragments, but it's still not typically strong enough for weight bearing. So you can often kind of see this procallus formation on X-ray, so we can kind of monitor that is forming. It has a different kind of appearance on X-ray though than normal bone. And even though it may look on X-ray initially that there's union of those bones, it's usually that procallus that's really not strong enough yet to support weight bearing. In the reparative phase, ossification starts to occur. And ossification is the conversion of that fibrocartilaginous cartilage that we saw in the inflammatory phase to more of a bony callus. In areas close to well-vascularized bone tissue, our osteogenic cells or bone-building cells develop into osteoblasts. And they produce this spongy kind of bony trabecula. Those newly formed osteoblasts deposit bone on the outer surface of the bone, a distance from the fracture site. And then the formation of bone progresses toward the fracture site itself until you have this new bony sheath that completely covers that fibrocartilaginous callus. Over time, that fibrocartilage is converted to spongy bone, and then the callus is called a bony callus. And then gradually the bony callus starts to further calcify and is replaced by more mature bone. The bony callus forms at about 3 to 4 weeks post-injury, and that process will continue until there's a really firm bony union. And that can form, it can take months for that full bony kind of callus to form. And the final stage is the remodeling phase. So during remodeling of the bony callus, dead portions of the bone are removed by osteoclasts. So those are our cells that break down bone. Compact bone replaces that spongy bone, first around the periphery of the fracture. And then there's reorganization of mineralized bone along the lines of kind of mechanical stress. So during this period, the excess material on the outside of the bone shaft and within the medullary cavity is removed, and compact bone is laid down to kind of reconstruct the shaft overall. The final structure of the remodeled area resembles that of the original unbroken bone. A thickened area on the surface of the bone may remain as evidence of a healed fracture. So even after complete healing, complete remodeling of that bone back to sort of a normal shaft, you might still see some evidence of, almost like bone scarring where you can pick those up. Sometimes we pick those up on X-ray where we see multiple old fractures. So we mentioned the term union, but union of a fracture occurs when the fracture is solid enough to withstand normal stresses, and it is clinically and radiologically safe to remove any fixation devices, whether typically the external fixation devices. Usually children fractures heal more quickly than adults. But some things that can delay wound healing, patient's age. The older that patient is, the longer it's going to take for that fracture healing to happen. There are some medications that can delay wound healing. Anything that blunts that inflammatory process will delay wound healing. Those with debilitating diseases, so patients with maybe vascular diseases or diabetes. Any local stress around the fracture site, so that's why it's important to kind of immobilize and non-weight bear on those fracture sites. Any circulatory problems, so vascular problems where we don't have good blood supply to the site of healing. Coagulation disorders, so patients who maybe have disorders where they bleed more readily, they may have more kind of initial kind of hematoma or damage to the bone itself that would delay healing. And anyone with poor nutrition. It takes, when we talk about some of those phases of wound healing, sort of that reparative phase, you need to calcify those bones. That requires there to be adequate amounts of those nutrients in the body to be able to work through that calcification process. So, some complications of fracture. The first one is loss of skeletal continuity, which we refer to as either malunion or non-union, where the bone itself heals, but we didn't have complete union of the two ends of the bone, so we heal with some sort of deformity um, at the bone itself. We can also get injury from bone fragments at the site of fracture. So if a segment of bone breaks off and embeds itself, maybe in some soft tissue around the area, that can cause further delay or problems with healing. Another complication of fracture, and we'll talk a little bit more about compartment syndrome specifically, is different injuries or complications that can be caused by pressure around that site. If you think about, bleeding around a fracture site, that bleeding can cause a lot of swelling in the area. And that swelling, especially if that swelling occurs in kind of muscle compartments, can cause a lot of damage. And again, we'll talk about that specifically with compartment syndrome. Fracture blisters are bulla, which are kind of raised areas on the skin that are fluid filled. More commonly, we refer to those as blisters. But those represent areas of epidermal or skin necrosis due to separation of the epidermis from the underlying dermal tissue, and that's usually caused by edema fluid. They happen when there's intracompartmental pressure, so pressure inside of the muscle compartments around the fracture. And if that pressure gets too high, we can't relieve it, one of the ways that it's relieved is through kind of movement of exudates and fluid kind of to the surface that causes separation of the dermis from the epidermis. We need to be really conscious of watching for fracture blisters because they do, again, can be a warning sign for increased pressure inside of a compartment, and they can be a warning sign for the development of compartment syndrome. We can also get involvement of nerve fibers or nerve pain from fracture. So complex regional pain syndrome, or CRPS, that's a neurological condition that impacts limbs and results usually from some kind of surgery or injury. So usually what we see in a patient is complaints of pain that are well out of proportion to the level of injury. And we also see some kind of vasomotor signs and symptoms, things like increased sweating and what we call vasomotor instability. So they might have kind of labile blood pressures and heart rates that drop or go up. Those are kind of the common symptoms of CRPS. And again, that's caused probably by damage or pressure on the nerves around the site of injury. And the final complication I have there are fat emboli development or thromboemboli. Thromboemboli are thrombus formation, so blood clot formation, either usually deep vein thrombosis development. These can be caused by the injury itself and coagulopathy following injury, and they can also be caused by the immobility associated with fracture. So if you get an emboli that forms in a vein, the most common complication of that would be that it starts to move. And as that embolus moves through the bloodstream, it can lodge itself usually in the lungs and cause what we call a pulmonary embolus. And so what you would see in a patient is chest pain and difficulty breathing, difficulty with oxygen saturation, would be, your common signs of that. A fat emboli is when um, um, pieces of literally of fat, and those usually come from the bone marrow and are released when a bone is fractured. Those enter the bloodstream and travel through and lodge themselves someplace else in the body. So the main clinical feature, the main sign and symptom you see with fat emboli, one is respiratory failure. So it might look like your pulmonary embolism, but now it's a chunk of fat kind of moving through the bloodstream that lodges itself in the vasculature of the lungs and causes and probably chest pain, difficulty breathing, and inability to oxygenate. So things like respiratory failure. If that fat emboli lodges itself in the blood supply to the brain, we can see cerebral dysfunction from that. So things like encephalopathy or seizures or different neurological deficits that happen suddenly with no kind of related head injury, no other reason. Those can be indicative of fat emboli. We can also see fat emboli that travel to the vasculature of the skin. So you might see things like petechiae form. Those are kind of little areas of kind of purple dots on the skin that represent damage to blood vessels at the level of the skin. Okay. Usually the signs and symptoms of a fat emboli develop within 12 to 72 hours of injury. So fat emboli is a pretty acute complication of fracture. Something like a thromboemboli might be acute or a chronic complication of fracture, again, because it can be caused by immobilization. If immobilization goes on for months, it could happen anytime during that fracture period. So the timing of those two things are a little different. So here's a little bit more about compartment syndrome. So within the body, the muscles and nerves of an extremity are enclosed in a really tough, inelastic fascia. And we often term that a muscle compartment. So you can kind of see that here in my picture. This is a cross section through a calf muscle, but you can see that overall muscle compartment. And inside of that compartment, these kind of little dots here, this represents maybe some nerves and some blood vessels that run directly through that muscle compartment. There's some bone here that runs through as well. So all of that is again enclosed in this really kind of tough, inelastic fascia. And because it's tough and inelastic, if anything inside of that fascia or that muscle compartment starts to swell, there's not really anywhere for it to go because that fascia does not stretch very readily. And so pressure can build up pretty rapidly within that muscle compartment because there's just, again, nowhere for that pressure to be relieved. So compartment syndrome is increased pressure within a limited space or within that fascia. And as that pressure builds up, it starts to compromise the circulation. So if those blood vessels are running through and inside that fascia, and we start to increase pressure, it pushes down on those blood vessels and blood doesn't travel as easily into that compartment. So it compromises the overall circulation to the bone, and it also squeezes down on the nerves themselves inside of that compartment too. So it can cause death of the nerve fibers and also death of those muscle tissues if we lose blood supply and innervation. Okay. Acute compartment syndrome is characterized by severe pain, usually out of proportion to the original injury or any other physical findings. So the patient will suddenly report this just increased, severe pain. And they often have paresthesias as well, which is numbness and tingling to the extremities as we cut off and compress those nerves within the fascia. If compartment syndrome happens, the muscle within that fascia can start to necrose or die really quickly. So one of the things with fractures to really watch these patients closely for signs of compartment syndrome because it does require rapid intervention to prevent that muscle tissue from dying. Um, so some treatment for this, it can include removing any pressure. So sometimes this compartment syndrome is happening because of external pressure. So if you have a patient maybe with a cast on or a really tight splint or something outside, that itself can, in addition to any swelling inside the muscle compartment, if you're compressing from the outside as well, that can lead to things like compartment syndrome. So if it's an external device causing that pressure, that compression, you would remove that cast. So you would, split the cast open to relieve that pressure. Sometimes we elevate the extremity to try to reduce overall pressure, but you have to do that really carefully because if you elevate an extremity that is undergoing compartment syndrome too much or excessively, you start to lower the arterial pressure to the site as well. And so if you're thinking about a muscle that already has compromised blood flow because of compression to those arteries, if you raise the level of that extremity up too much, it makes it even more difficult for blood to go to the area because of the effects of gravity. So we can elevate, but we have to do it very carefully. And if elevation starts to increase that pain, we may want to remove that elevation. Okay. The final course of treatment for compartment syndrome is something called a fasciotomy. This is really treatment of last resort because it causes a lot of tissue trauma, both to the dermal and epidermal layers and to the muscle itself. It has high risk of things like infection. It has long-term, it takes a long time to heal. But essentially what it is, a fasciotomy is where it's a surgical procedure where we split open that outer fascia, usually kind of the long way, right? So if you have a leg, maybe you have a quadricep compartment syndrome, you would make a long incision all the way through the fascia, from, proximal to distal in that compartment to really just kind of open it up and relieve the pressure. But again, it causes an extensive amount of tissue trauma, takes a long time to heal. But if it's between losing the limb and doing a fasciotomy, that is the surgical procedure we do to release that pressure. Okay, so another complication of fracture or of any kind of procedural stuff to bony tissue is something called osteomyelitis, which is inflammation and infection of the bone. So there are several different causes of osteomyelitis. We're going to focus on this direct penetration and hematogenous spread. So we'll start with direct penetration. So this is contamination of either an open fracture or from a wound. And the bacteria is what we call exogenous in origin, meaning it's coming from the outside and being introduced directly into the wound. So direct penetration osteomyelitis is the most common cause of osteomyelitis in the United States. What we see is bacteria being introduced directly into the bone by some kind of penetrating wound, or through an open fracture, or from some type of surgery where we get seeding of bacteria in a surgical procedure, usually through the skin. So this can be caused by pin tract infection and skeletal traction. So I have some pictures of that here. So sometimes we use what we call external fixation devices post-fracture, where we have pins that travel directly through the skin from the outside and into the bone. We have to use really special care with those pins, keeping them clean, because bacteria can crawl their little way right down that pin and directly into the bone. So this picture represents pin site infection. So you can see it started out as just kind of some redness around the pin site. then we can see some kind of crusting and further kind of opening up of that pin site itself. And as that progresses, we can see kind of a large open wound at the site of the pin that's not really healing. And anytime we see that infection externally, that bacteria can also make its way down directly into the bones. That would be a type of direct penetration osteomyelitis. We can also see this direct penetrating osteomyelitis from infected joints from joint replacement surgery. So if bacteria are introduced through surgical joint replacement surgeries, that can cause osteomyelitis. And we can also see this through wound infections after surgery. So if someone has an infection of a large wound post-surgery, it can make its way down into the bone. So these infections are usually staph or strep because that's largely the bacteria we have living on the skin. So that's the most commonly introduced bacteria to the bone. Osteomyelitis after trauma or bone surgery is usually associated with persistent or recurrent fever, increased pain at the operative or trauma site. We might see poor incisional healing, wound drainage, or even separation of the wound. Again, kind of like what we're seeing down here in this piece. If it's an infection of a prosthetic joint or a replaced joint, we often see increased joint pain past the time of healing. We see fever. We might see drainage at the skin itself. Okay, so that's direct penetration, but hematogenous spread is the other type. And this is when we get infection to the bone from direct seeding through the bloodstream. So we get some kind of bacterial infection into the blood, and it makes its way to the bone and takes up residence and starts growing there. So the most common, we see that most commonly in children. Because of the different ways that the vasculature of the bone itself changes in adults, the adult vasculature of bone isn't as readily seeded with bacteria as it is in children. Children's bones tend to be kind of more vascular because they're still undergoing growth. Usually around the areas of the growth plates is where the most vascularity is, and that's also where we often see the development of osteomyelitis for that reason. In adults, if we see this type of osteomyelitis, it's usually because it's a very debilitated adult, maybe with chronic infections of either like the skin or sometimes urinary tract infection. We also see this in IV drug users because they have a high probability of seeding bacteria directly into the bloodstream with kind of low immune function. And we also see it in patients with weakened immune systems more often, either weakened immune systems through disease or from medications like corticosteroids. Okay. Signs and symptoms of acute hematogenous osteomyelitis are those that look like what we call bacteremia. Bacteremia is bacteria in the bloodstream. So that's things like chills, fever, and malaise. There's usually pain on movement of the extremity, loss of movement, tenderness, redness, and swelling are common clinical manifestations. So treatment for both direct penetration or bloodstream seeding initially is first identifying the microorganism that's causing the infection so that we can administer appropriate antibiotics. Oftentimes these need to be IV initially. We may switch to oral once there's some control over the infection itself. Typically, the course of infection for bone infections is quite long compared to other types of infections. So usually a long course of antibiotic therapy. Surgical intervention may be required, things like surgical debridement or kind of lavage or sort of clean out of some of that debris or infectious buildup in the bone might be necessary to kind of help along those antibiotics, especially if there's a significant amount of infection. If it is like a pin or a prosthetic joint, that's causing infection, those things need to be potentially removed. Prosthetic joints, if they become infected, they do need to become removed. They do need to be removed because a prosthetic joint does not have blood supply. It's prosthetic. If there is, if you're giving antibiotics, those need to travel to the site of infection via the bloodstream. So if you have an avascularized joint replacement, you will not be able to remove any infection from something like that. So the joint itself completely needs to come out. We also see chronic osteomyelitis. So those two things we were just talking about were really acute osteomyelitis, but sometimes it happens chronically. Um, so this picture shows some of the hallmarks of chronic osteomyelitis. And the hallmark feature of chronic osteomyelitis is the presence of an infected dead bone area. We call that a sequestrum. That's an area that has been separated from living bone. So in my picture here, you can see the initial site of bone infection was here. We lost kind of blood supply to that area of initial infection. We may have seen some abscess or pus formation kind of on the outside during the more like acute phase. And then what ends up happening is we have this little area kind of dead bone inside of the healthy tissue itself. So that's the sequestrum, that area of dead bone. And surrounding that sequestrum is new bone formation. And we call that the involucrum area surrounding the sequestrum. Okay, so this, again, hallmark of chronic osteomyelitis. So chronic osteomyelitis is any inflammatory process of the bone, except those that happen in rheumatic diseases. So anything caused by microorganisms. Rheumatic diseases are usually caused by autoimmune destruction. These are caused by microorganisms. So chronic osteomyelitis usually occurs in adults. And usually these infections occur secondary to some type of open wound, most often to the bone or the surrounding tissue. So treatment, initial antibiotic therapy, often followed by surgery to remove the foreign bodies. If it's metal plates or screws that are causing it, if those are in place, we might take those out. And we also do surgical intervention to remove that sequestra. And again, antibiotic therapy is kind of long term, takes a long time for these things to kind of heal up. Okay, while that's healing, and if we do have to go in and remove a sequestrum, a mobilization of the affected part is usually necessary. We usually have to restrict weight bearing if it's on a lower extremity. So a certain degree of immobilization will be required during that healing process. So we'll also talk about some bone tumors. So two types of bone tumors we're going to talk about: primary malignant tumors and metastatic tumors. So we'll start with primary tumors. So primary malignant tumors, meaning malignancies that develop in the bones themselves, they're relatively uncommon. Less than 0.2% of all cancers are primary malignant tumors of the bone. But metastatic disease of the bone is relatively common in patients with other types of cancer. So some common symptoms of bone tumors, so pain, and it's often pain that persists at night, that's unrelieved by rest. So sometimes people have, maybe pain during the day that with rest kind of goes away. With malignancies, that pain persists often through the night. Other signs might be the presence of a mass that you can see and or palpate at the surface, and also impairment of function. Another sign is often pathological fracture, which is when a bone breaks from minimal pressure trauma. So there are different types of primary malignant bone tumors: osteosarcomas, Ewing sarcomas, and chondrosarcomas. And this little picture kind of came out of your book. It shows sort of the different areas where we most commonly see these different types of tumors. So you can kind of look at that and review where these are seen, but we'll talk about these. So we'll start with osteosarcomas. Osteosarcomas are very aggressive. They are highly malignant. They most commonly arise in the vicinity of bone growth. So the knee or distal femur or proximal humerus. So you can see here my osteosarcoma. So here's areas of the knee or distal femur. So these are areas of growth. Here is the proximal humerus, again, areas where we see bone growth. That's the most common site of osteosarcomas. Okay. They are more common in boys, and really we only see this in people under the age of 20. So osteosarcoma is really more of a childhood type of cancer. Remembering that one of the common things in childhood cancers are that they originate from things like connective tissue, um, unlike what we see in adults, right? Prognosis with an osteosarcoma really depends on how aggressive that tumor itself is and how much it is metastasized. Um, Treatment, chemotherapy, surgery, and if because they're so kind of aggressive, if chemotherapy and surgery are not keeping that tumor growth under control, amputation may be necessary to just remove the site of malignancy. Another type of primary malignant bone tumor is something called a Ewing sarcoma. Ewing sarcomas account for about 2% of childhood cancers. They can occur at any age, but most commonly, by far, we see these in people younger than 20. We rarely see them after the age of 30. Males are affected slightly more frequently than females. The most common site of Ewing sarcoma formation is in the femur. So here's my Ewing sarcomas in uh, green here. You can see the femur being one of the common sites. We can also see them other places like the pelvis, um, the humerus, the tibia, but most common we see these develop in the femur. They can be pretty difficult to diagnose. Um, Diagnostic biopsy might be necessary to diagnose Ewing sarcoma. Treatment, chemotherapy, surgery, and radiation. The other type of malignant bone tumor is a chondrosarcoma. This is a malignant tumor of the cartilage. And this is the most common bone sarcoma that we see among adults. It's the second most common primary malignancy or bone cancer overall. The timing of this, it usually occurs in middle or later life, and we see it a little more often in men. Chondrosarcomas are pretty slow growing. They don't metastasize very readily, usually late metastasis, and they respond pretty well to early treatment. And you can see chondrosarcomas are in blue, some of the more common sites that we see those develop. Metastatic bone disease is bone lesions caused by metastasis of some kind of neoplasia from a distant site. So the common clinical manifestations that we see with metastatic bone disease are pain and pathologic fracture. We diagnose these usually via PET scanning or bone scans. We can do radiology or CT scans, but they do sometimes miss early metastatic lesions. PET and bone scans are usually more definitive for finding early metastatic bone disease. So the more common sites that we see metastasis are in the spine, femur, pelvis, ribs, sternum, proximal humerus, and sometimes in the skull. And the most common sites that spread to the skeletal system are tumors of the breast, lung, prostate, kidney, and thyroid. So with metastatic bone disease, our goals of treatment, one is the prevention of pathologic fractures. So whether that's immobilization or, different safety interventions. Another is promoting survival with maximum functioning. Oftentimes patients with severe metastatic disease may have, more difficult to treat cancers with more poor prognosis. Um, and then allowing a person to maintain mobility and to control pain is another goal of treatment. So we can treat metastatic bone disease through things like chemotherapy and radiation, and also surgical stabilization. So sometimes we do maybe internal fixation devices on areas with bone metastasis to prevent pathologic fracture.